Thank you for joining us. It's my pleasure to host the April webinar with Josh Richardson and Wiplove Lamba on the topic of addiction psychiatry, addiction psychotherapy, more than just motivational interviewing. I love that title, and I think it captures what all of us would really like to hear about. I'd like to start with our land acknowledgement. I'll introduce Josh and Wip and the format for tonight's session, which is pretty similar for those of you who've joined us before. We acknowledge that the lands on which we're hosting this meeting include the traditional territories of many nations. These are the ancestral homelands of the Huron-Wendat, the Anishinaabeg, the Mississaugas of the Credit, the Haudenosaunee, and the Attawenderons, neutrals, and is home to the Dish with One Spoon Treaty. Medify recognizes that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. Medify respects that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. And I invite us to reflect on the territories we are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. So thank you again for joining us for tonight's webinar. I'd like to introduce our speakers. Josh Richardson is a registered psychotherapist and practical nurse with postgraduate training in philosophy. He currently provides substance use support at Saugeen First Nation in Nigmig, Cape Croker, as part of a collaboration between physicians from the Owen Sound Family Health Team, Grey Bruce Health Services, the Mino Bimadsawin Health Center at Saugeen First Nation, and the Chippewas of Nawash and Unceded First Nation Health Center. It sounds like we should have another webinar on that collaboration, Josh. We should.
Oh, it's amazing.
It's a wonderful topic. Let's
that would be fantastic.
Come back to that.
Yeah.
Josh lives with his 3 sons in Owen Sound on the traditional territory of the Ojibwe, Potawatomi, and Odawa, or Three Fires Confederacy. And Wip Lamba is a fellowship-trained addiction psychiatrist who has worked at CAMH, St. Michael's Hospital, and Ontario Shores Centre for Mental Health Science. He now works at Mount Sinai and Joseph Brant hospitals. Wip has been involved in learning and training other people in psychotherapy with the goal of including people who use drugs. These therapies include motivational interviewing, community reinforcement approaches, seeking safety, dialectical behavior therapy, and cognitive processing therapy. He has been the medical co-lead of Project ECHO, Addiction Medicine, and Psychosocial Interventions since its inception 4 years ago, and will be co-leading a pilot for hospital-based addiction care this summer. Wip looks forward to sharing what he knows and learning from all of you how to provide better care for those he serves. And really, thank you for all that we serve. So I'm handing things over to Wip and Josh for the next hour and a half. I invite everyone to please put questions and comments in the chat space. I think the intention is to try to include and incorporate some discussion as we go. Of course, we'll have a more formal question and answer period in the last half hour of the session. But please don't hold back. Josh is here to keep an eye on things and keep them lively. And I'll just remind you to please complete the evaluation survey that will pop up on your screens just before the end of the session in case I forget to announce that again at the end. So thank you, Wip and Josh.
I'm just looking through all the names and there's a good crowd.
Yeah, very skilled clinicians in the list. So hopefully we have something we can add to their practice. So a lot of familiar names and people quite familiar with this patient population that we all serve. So I guess the title of the talk, even though it was about adapting psychotherapies to use them with people who use drugs, and the talk that I'm giving is more about different psychotherapies I use for people who use drugs. But the hope is that this back and forth that I have with Josh as we talk about implementation, you're going to get some ideas about what to use in or how to change some of these therapies to be applied to your day-to-day clinical practice. I mean, we all read those books. This is what CBT is. This is what that is. But in real life, it ends up playing out a little bit differently and stuff. So I have some disclosures like physicians tend to have, and Josh has none related to this. And the three objectives, which are going to come out more in the implicit dialogue, and the more that all of you bring out, have to do with describe some different types of therapies that you can use with people who use drugs. Talk about practical, real-world adaptations for psychotherapy, and then also explore and appreciate how different approaches might work with different clients. And if we don't get much fuel in the chat, I've got a couple of potential cases that Josh and I can brainstorm around what might work and what might not work. Um, and here's just sort of a quote. If you treat an individual as if he were what he ought to be and could be, he will become what he ought to be and could be. And so this talk is going to cover, in terms of becoming a psychotherapist, Josh's story and my story. We're going to talk a bit about understanding the patient. Not going to go into addiction medicine because with all the Meta-Phi stuff and the RAM stuff, people know addiction medicine pretty well. And the themes for the psychotherapy piece fit into a couple of broad categories: engagement, how to think behaviorally, personality, and trauma. But there's much more to psychotherapy than just that. But I just wanted to go through that part quickly because I think when you hear competent therapists, I mean, I'm talking more about Josh than myself, but when you hear about how they built that comfort level in their approach, we start to get ideas about what might work, and so, Josh, I don't know if you wanted to talk first or I talk first, just around our journey
Sure.
to being a psychotherapist.
If you want to go ahead and give your history, then I can follow you if you like.
Sure. So, yeah, sure. Let's do that. So I did my psychiatry residency in Toronto, and immediately when you think psychiatrist, you think, oh, they've had psychotherapy training, and especially now. I mean, I'm running groups. I sometimes give workshops, but this wasn't a skill that came naturally to me. I think in residency, if you saw me in PGY2 and I gave my grand rounds, I think I was staring at the screen the entire time. Half my presentation was a description of the patient history. I think I had 6 months of group training, which involved being in a dark room with a video camera, and we were teaching patients with dementia how to do like CBT skills, right? And so it was almost like what's that thing where it's the same session over and over again, where you're covering the same concepts because they didn't have the ability to absorb it. And in fact, I mean, I never know if I should share this. If you were to talk to my wife when we started dating, she actually had to have a talk with me, and she was like, "Whip, when my friends come over, people come over that I care about, you have to make eye contact with them. You have to show genuine interest in what they talk about." And at first, I thought she was joking, but no, she was serious. And I think it's something that we assume that this is a skill that comes naturally, for people, and that, oh, because you're in psychiatry, this is, and for me, it was something that developed over time, and it developed with a mentor. When I started at St. Mike's, I thought I knew addiction. I finished psychiatry fellowship, addiction fellowship. I did that US exam. I was ready to spread buprenorphine and alcohol withdrawal and naltrexone and all that stuff to the world. And a colleague of mine, we'd have these gentle dialogues over time where he gradually helped me see some of the gaps in the care I was providing. And over time, I ended up doing a few extra trainings, running a few extra groups, even though it was not something I ever imagined on doing. And even though I don't think psychiatrists should be spending all their time doing group psychotherapy, I think there's a lot of people that are more efficient uses of resources. It's been transformative for me. And for each one of these therapies that I talk about today, I went through a learning journey where I learned about it after I was done my residency. And so there's just some of the thoughts that I want to share with all of you, and it might come out in some of the talks about this therapies, about how I was able to pick it up. Josh, I look forward to hearing your story a little
Well,
bit.
well, you're very kind, Whip, to describe me as you did. I gotta say, I met Whip first doing the Echo series that he was describing, and I would encourage any and all of you, if you haven't done it, if you want to improve your skills, it's a fantastic thing to enroll in. And I was impressed with Whip's knowledge and enthusiasm regarding psychotherapy. Not only because it was infectious, but here was a psychiatrist who was talking about doing psychotherapy, and I had not really come across that in my work. As Jennifer was saying, I started off in philosophy and was interested in philosophy of psychiatry, and then wanted to gain clinical experience, trained as a psychiatric nurse and then as a psychotherapist. First, I worked with people with diagnosed with serious mental illness, and then I moved over to addictions. Yes, I'm very excited to go through this with Whip, and hopefully you will find some very practical suggestions and things you can start with here and explore further, ask questions about them, follow up with readings, because there are things that you can start to do really in your everyday practice that I think we'll be talking about here right off the start after this. Anyway, go ahead, Whip.
Yeah. So the way that it's designed is that I'm first going to just present a framework about understanding the patient, and the reason that I do that is because it just I mean, I guess I'll explain why, but basically it's the stuff I said before. So understanding the patient, maybe a bit about addiction medicine, because a lot of you do work in a RAM clinic. I mean, I think Medify, that was the initial push, was to create those RAM clinics, and then it's about 3 to 4 broad categories that include evidence-based psychotherapies. And so I'll just go through the talk, and I'll try to keep all the storytelling relevant to the content and stuff. So there's this quote. So a good friend of mine and a mentor who taught, like, who actually, I think he planted the idea of the importance of being a psychotherapist to me, Tim Guimond. He did his medical school in John Hopkins, and over there, once you're the head of a department, you get to sort of pick what the trainees will learn. And over there, they weren't big fans of the DSM-4 or DSM-3, whichever it was, when he trained, and they believed that they really allowed the biopsychosocial model to become the bio model. And the way that they were trained to do psychiatric assessments was, when you meet someone, you meet with them for an hour and a half, and you go from birth until present. It was just sort of a very different model. And at the time, I think Tim, maybe he just wasn't sure why they were doing it so differently than everywhere else. And I think after he was out in practice for a couple of years, he really sort of saw the value in it. And I mean, Josh knows, I mean, we sometimes do 30-minute sessions. I've done 3-hour workshops on this model with colleagues. But the thing I want you to remember as I'm going through this is that all models are wrong, like in some way, inherently wrong, but some of them are maybe a little bit useful. And for me, this model is very, very useful. And it talks about 4 dimensions of understanding the person. The first dimension is the disease component. So the theory behind this is that there's like a cell or something that's broken, like you would see maybe in schizophrenia, or something in bipolar, maybe in severe treatment-resistant depression, where there's just some things that haven't been activated. You'd see it in delirium. But there's something like physiologically not functioning as it could be or should be, and there may be some kind of medication kind of intervention, or ECT or something that may help with those cluster of symptoms. The second broad category has to do with dimensions, right? And we can all think of a couple of things where human beings fit on a normal distribution. And if you're at the extremes, it may cause problems for you in life. So one could be maybe height. Height could be one of those things. So if you're 7'10", it's going to be hard to get in a car. If you're 4'3", there's going to be other challenges that come as well. And the same thing happens sometimes for IQs as well, right? So if your IQ is below a certain amount, maybe there's certain skills you're not going to be able to grasp or achieve. And I don't know if this is scientifically based, but I have this suspicion that people that are extremely high IQs, maybe not so good socially, but I don't know the data on that. That's more of an assumption based on watching TV shows and stuff. The other part has to do with the 5-factor model. And Josh, I apologize. I actually know what, maybe I can rely on you if I start to speak a little bit fast, because I do get a little bit.
No, this is good. Keep going.
Okay, all right.
And I'm looking for the questions. No, you're
look for the questions. I just know if you're looking for the breath, the breath.
Look, the breath. Yes. No.
So
I go ahead.
So the part that they talk about with the dimensions has to do with that five-factor model or ocean. So some of you that have done first year
Mhm.
psychology, they may cover that in that. And so ocean talks about these five dimensions that from their 20s to late on in life, and some people would argue from earlier on, people almost fit pretty consistently on some area of it, outside of if they've had like a manic episode or depressive episode or some major life event. So ocean is openness to experience, conscientiousness, extroversion, introversion, agreeableness, and neuroticism. And I think there's a lot of different things in different uh, literature where they talk about things that are similar to this. They talk about like dandelion versus orchid kids. So, what are dandelion kids like? Dandelions, well, you can imagine they grow anywhere. They can grow in rocks, they can grow in gravel, they grow through cement. You can't get rid of them no matter what you do. And orchid kids are beautiful, but they sometimes need the right environment, the right humidity, the right moisture, the right amount of sun. Too much, too little. It doesn't allow them to develop. And with these things in the dimensions, if people grow up in an environment where they have positive role models, they have people to teach them the skills. So one story my friend always talks about is how even though he's highly social, he's an introvert by nature. But when he was a kid, his mother taught him that if someone throws the ball at you, and you don't respond. Someone throws the ball at you again and you don't respond. The third or fourth time they stop throwing the ball at you, right? And so it's important to learn that skill on how to catch and throw it back. And so you may have someone who's bit wired more as like this introversion kind of a personality style, but they've learned the skills in order to function that they can catch the ball, throw it back, and play catch for a little while, sort of thing. And so there's that temperament, dimensional kind of piece. The third part has to do with behaviors. And the embarrassing part for me to say is I go through a psych residency, I do cognitive behavior therapy, I do an addiction fellowship, I learn about addiction medicine, pain, concurrent disorders. I wasn't thinking behaviorally. And some of you may have had this, some of you may not have. But when I was taught cognitive behavior therapy, is really was that cognitive therapy component. I wasn't going with people into the elevators, right, to get them comfortable with phobias. I wasn't going to people's homes to help them with hoarding and moving stuff around. It really was more. And so when this world of the behavioral approach opened up to me, it was almost like the curtains were opened. I saw the sun and I could not see it anymore in any other environment I am in. And so with the behaviors, we think about antecedent, behavior, consequence. And for those of you in medicine who work in a nursing home, you're always thinking this whenever there's a behavioral kind of issue that goes on. Those of you that have children, you may be thinking like what's bringing on that behavior, like what happened to you to bring it out. And it's also done by cravings as well. So it's guided by cravings and urges and desires. And then the fourth part is sort of the life story piece, like what's happened to you, what's shaped your narrative and your view of the world. So it's almost like a disease is what the person has, dimensions is what a person is, behavior is what a person does,
Mm.
and stories is what a person has encountered. And here's a nice little cartoon. And Josh sort of had the book, the Perspective of Psychiatry book, and the
I
reason.
Yeah.
Oh, sorry. Go.
No, no, I found it so useful in the presentation that Whip gave the layout of it because it presents those four dominant almost schools of psychiatry in a kind of simple breakdown. Anyhow, go ahead, Whip, please.
Yeah, and the reason that it really spoke to us and Tim Guimond and myself after he I don't know if he indoctrinated me in this philosophy or what, but it fit with the stuff we were offering, right? So we have this disease model for psychiatric, some addiction medicine, but addiction medicine probably fits more in a behavioral thing. We were offering a DBT skills a piece, which fits with the dimensions and the behavior side of things. We had a motivational interviewing and community reinforcement approach that I'm going to talk a bit about today, where you're really thinking behaviorally, right? Antecedent, behavior, consequence, and how to shape that behavior and teach people how to replace the function of the substance use. And then once you start getting into trauma, you get into their life story, like what are the experiences they've had, how has that shaped their worldviews, and which ones of those worldviews are helpful for them, or which ones do we need to help them reshift and shape, like we would with the CBT once we start to go a little bit deeper. And the reason that I bring this up is I really believe our standard assessment doesn't have that broad framework in mind. And if you look at any of my consult notes, I don't talk about this stuff, but there's something about having that knowledge in the background. It makes me start to think, what are the different treatments we can offer for this person in front of us, because I've not read a great guideline on complexity. And what I'm stuck doing is what a lot of you are doing, where we're pulling from these different evidence-based approach and trying to find this complex patient that normally isn't eligible for a lot of the trials they do for these therapies. So that's the perspectives of like in terms of understanding the person. Josh, I don't know if you have any sort of comments to add. It's a little bit hokey, but I mean, I like that as the backdrop, because when we start thinking about the psychotherapies, we start thinking about our work context. It gives a framework in terms of what's the component of the individual we're trying to shift and shape. You know, we don't want someone to be like, oh, I went to this group, it didn't work. I tried this med, it didn't work. I did no, but how didn't it work? Was it
Well,
that you
and
weren't?
I was going to add it. It then it walks us into the next framework where you'll see uh, the different aspects of this personality disorder, trauma, etc. What what to pair with what concurrent disorder. So I think it sets things up very well.
Yeah, and you know, I think Jennifer makes a great comment around the concept of addiction as a disease, and how it alters our approach. And when I first learned about this, I immediately, just because I'm trained in medicine, I was like, oh, an addiction, it's a biological thing. But technically, sort of when you look at the behavioral component, where it's like antecedent behavior consequence, and you think about methadone, what's it doing? It's reducing withdrawal symptoms. Right, and that's an antecedent for some people. Sometimes it's the withdrawal symptoms that triggers the use, right? And so in some cases, the
Mhm.
methadone may be preventing the withdrawal, maybe reducing the risk
Mhm.
of overdose. Is it treating the disease? I'm not so sure. And I think the training in dialectical behavior therapy helped me a lot, and also maybe watching the way the world is so divided. You know, you almost
Mhm.
have to try to find that kernel of truth in different approaches. And I know for myself, you know, when I started doing addiction work, I was taken back by all the stories where I would see people where 12 steps had transformed their lives, because it wasn't a big part of the training that I did. I was really trained in the medical model, and now with harm reduction, where the 12-step approach has failed a lot of patients, I still try to keep that kernel of truth in mind, where there's a subset of people where it's been transformative for them. And so for me, for the disease versus the non-disease, I just try to find the kernel of truth. I try not to lie to myself or lie to patients. And I just try to figure out what's the narrative that they have of the world that I can work with. What's the way that I can be honest with them about my views, and maybe I'm a bit manipulative because I share the parts that match their viewpoints to start. But I still have to make sure that by the time I'm done working with them, they know what a psychiatrist would suggest, they know what an addiction medicine doc would suggest, they know what a harm reduction worker would suggest, they know what a family physician would suggest, they know what a caseworker would. So they have these different sort of viewpoints, right? And so I mean that's the way that I look at it. But it's just I prefer not to get into the conflicts and stuff. So yeah, so some great
So
comments, right, on social versus
yeah.
DNA. I never know whether I should keep talking, Josh, because
Oh no,
every
I think it's great. I You also mentioned how we were thinking of it in terms of harm reduction as maybe the outlying shell, which can help foster engagement, as you have here right now. The slide about engagement in course of therapy. So I'll let you proceed, Whip.
okay. Great. So this is just a slide that I use because when I think about where I got to be thinking about psychotherapy and providing psychotherapy, it was a context at St. Michael's Hospital from 2014 onwards, where we rolled out our RAM clinic, or we called it RAC back then. And what a few people did was they set it up so that in the first visit, the person saw a caseworker, case manager, so they could figure out what their needs were in terms of detox or programs or long-term kind of stuff. And it was also something where you have to shift your approach from a traditional psychiatrist. You start to think like family docs do. So how do family docs think? I mean, I'm making it up. I'm not a family doc. Who am I to tell you how they think? But one thing they're very, very good at, they're good at taking complex patients with 50, 60 issues and breaking it down into 10-minute visits once a week to get through the stuff. And when we think about the addiction medicine clinic and the RAM clinic, you can't think like a psychiatrist where like, hey, can I get an hour and a half assessment done here? Like you would at John Hopkins. Would I get a 46 minutes? That you're lucky to get 5 minutes, you know, with some of the patients that show up there. And so I really think about how do I hook them in? How do I get them to come back in the engagement piece? I make sure start with some of the addiction medicine recommendations, like are they in alcohol withdrawal, are they intoxicated, substance related psychosis, does the psychosis linger, like what would an addiction medicine doc do? And then in the back of my mind, because I mean, once they're coming back, you can do the rest. I mean, I think that's one thing that I love about method when people come back, right? If someone's coming back, it's almost like you're having dialogues regularly. But if when they disappear, that's when I worry the most about people that we see. And so this is the part that I think is gone quite good in the REM, and they're evolving. They're including more and more substances. But the part I think a lot about is what's going on behaviorally. I think back to a couple of patients I worked with, where they were using crystal. I think back to my assessments in 2016. Oh, you've relapsed? Okay, let's try to keep you sober. I'm not asking them what they're doing. I'm not asking how they're spending their time. I didn't realize I was competing with, like, for some of these men, I was competing with either like a weekend where they use nothing and they have nightmares and flashbacks with their trauma, or they just have 3 days of great sex followed by psychosis, right? And it's hard to
Mhm,
compete with like
mhm,
3 days of great sex, right? So it's when you start thinking behaviorally, you start to think, what does the drug do for this individual? How can I help them develop other skills so they can replace the function of that? Is there anything that we can do so their sober life is more rewarding than the one they're using? And it's so embarrassing for me to say that wasn't a part of my initial assessments when I started working in addiction. Long term, I mean, I just put EPE there just because I think it was a part of an old slide deck that, there's ways you can sprinkle in MI when you're giving advice, when you're doing your doctor stuff that you do. But I really try to think about what are the medical and psychiatric comorbidities that are being missed. Because once you start getting them to come to those RAM clinics, then you could do the other stuff. And the main reason that I share this backdrop is because I think we normally think about psychotherapy or what psychiatry does as something that's so far off. It's like up in that ivory tower. They can go on that Thursday in 6 months' time and start getting that trauma treatment. They can go to that 8 month long program that they'll get into after a year, and they could do that. But the reason that I'm bringing this is because I believe there's ways we can start to sprinkle some of these ideas earlier. We can start the interactional stuff earlier, so that we can have patients that within 2 years, they can figure out, oh, maybe they do have borderline personality. Maybe they would benefit from dialectical behavior therapy. Hey, you know what? Maybe they've got a complex trauma picture. Hey, we've got some good treatments now for complex trauma, for actual PTSD. Can they get through it? Let's figure that out too. And so I think this is why I just want to explain in this context, because in the past, when I talk about this, they think I'm like some psychotherapist that's done like philosophy and done this and trained under Freud, and really I'm just this like guy that used to be good at numbers, just very curious about people, and very curious about stuff. And maybe it was my way of rebelling my mom's desire for me to be a surgeon. I don't know, but
well, I again, and as I emphasized in the chat, this framework is very practical in many ways, and again, it will lead into how you break down the paired psychotherapies with the concurrent disorders. Um,
great. So I'm just gonna skip this because this is what I try to do. This is when I bring my psychiatry hat in. Like once they're coming, they've gotten their addiction medicine, but that's for another time. But this is a nice
yeah,
cartoon or figure. My friend and colleague Kate Vegda put this together because we both spent a lot of time with Tim Guimond trying to see these patients, trying to offer the different psychotherapies. And I just like this figure, right? I mean, the only thing missing is probably this like a background of harm reduction and treating people like humans, and
right.
all that other stuff there.
And we mentioned in our talks before presenting that something like providing clean syringes and other harm reduction supplies, even food and snacks in the setting where I work, is a way of engaging people who are pre-contemplative, aren't necessarily interested in treatment yet, aren't with a RAM clinic or taking methadone, and that's that broader shell as I was talking about. Yeah.
Yeah, no, absolutely. And there is something about, when you see someone and they're like, you know what, I don't want to get an infection, and you give them a clean needle, and then they use the clean needle, as opposed to one that may have more bacteria and stuff on it. They're telling themselves that, I'm worthy. I'm worthy of having a clean needle. I'm worthy of not getting an infection by this. And there's this implicit message that, I'm worthy of love. I'm worthy of a better life, because it's almost this indirect way that they're taking care of themselves. And so, I mean, but once you get them engaged, this is where this comes in, and the three main themes here are, one is, the MI piece, because I feel like for some patients, if you haven't gotten the harm reduction stuff, you don't have them coming in regularly. It's really hard to have those talks around the MI. There's the behavioral component around for the specific substance use behavior, right? And this is something I'm going to talk a little bit about today, at least two, three ideas that'll stay with you. Then what do you do around the trauma? And then what do you do around the personality? And this is when I think about the time that I feel like we had a really good thing going. We had a MI/CRA stream, we had a DBT stream, and we had a seeking safety stream that was followed by cognitive processing therapy. And there was a few patients that I didn't think we'd ever be able to engage. Then in about a year and a half to 2 years, it was transformative. What you saw in terms of how they're looking at the world, how they were looking at themselves, and so forth. And the hope today is that you get a couple of key ideas around all this stuff, and then you'll pick one of these and do a bit of a deeper dive if it's going to help the people that you're working with, and complement the approach that you're currently taking. Okay. Yeah, I guess it's sort of like the take home is really just around the engagement, right? Because once you have somebody coming in, then the rest can happen. I'm not going to go through the addiction medicine assessment here. I think there's a lot of Medify material on that. I'm also not going to go into harm reduction too much, but I just love what I'm seeing now. I remember when we started our RAM clinic, we had to hide the supplies. We had to like put it in a closet and then pull it out when the clinic started, and then put it away afterwards. And then eventually we just sort of like left it out, forgot to sort of put it away. I remember a talk I gave, I don't know if it was 2016, 2018, where like there was 2 out of the 40 people had seen a harm reduction kit. And then 2 years later, I gave the same talk, same environment. It was 2 people that hadn't seen it. So it's transformative about what's there. And I normally think about the States and Harvard and all that stuff about like, oh, they're so far ahead of us. But in terms of harm reduction, we're so far ahead of the game. And there was that great talk last month through the Medify portal as well. I really enjoyed it. There's so many people that have these stories, and each one of them, it really just I don't know, they really stay with you. The great thing about harm reduction, there's tons of free stuff that you can sort of provide, but unfortunately you can't really integrate it into your team unless you have someone with a lived experience there on your team as well. I feel that's when the magic really happens. Contingency management, I wasn't planning on talking about it, but after Josh's Medify thread, I was like, we have to do it. And this book is really phenomenal. And for me, I
Mhm.
mean, I've had some success with attendance in groups with the fishbowl method, not so much in an open environment. Occasionally, you can sometimes get people to get their IV antibiotics if you give them a certain medication at the same time, or if you give gift cards, things like that. But I think we're going to have to really figure out how to shape people's behavior in a way that's effective and helpful, because sometimes people have goals of using less, right? But they're just not sure how to stop. And there's very clear evidence for how this could work and help. The great thing with this book, it's a complete how-to guide. It even has like a chapter on how to talk to your boss about implementing it, how to write up a business proposal and stuff. There's certain people in this world that are just phenomenal human beings and do phenomenal work. And I suspect Dr. Petrie was one of those people as well, because the book is so well written. Um, I just wanted to share this because this was a paper back in 2020. We talk a lot about stimulant replacement therapy. I don't think we put value on the fact that there's been a lot of negative studies that haven't worked in some treatments for stimulant use disorder. We don't put a lot of fact. There's a signal. There's a signal in contingency management plus a couple of CBT-like therapies like CBT and CRA with counseling. And I mean, I don't even know where to get those outside of these hodgepodge efforts that some clinics I've worked in, we've tried to put together ourselves. So I feel like we discount the negative studies, and we don't try to spread the therapies that we know work for this. And I think I probably don't need to cover this, right? Because it was an article that Mel posted, and I think he had a couple of paragraphs that talking about the value in the Medify post that
Do
he
you,
had.
do you want to give a brief description of what
Oh,
contingency management is, or
yeah, sure,
uh,
absolutely,
yeah,
absolutely.
yeah.
Or you can. Why don't
Uh,
you, like, Josh? You want to do it? You can do it too. Or
Well, I can give a quick description. Essentially, it's a targeted therapy for abstinence, uh, um, and it's basic operant conditioning. When a person tests negative for the drug that's being targeted, they're given a reward. there are different systems of reward vouchers. We're using small denominations of Tim Hortons cards, and in succession, the reward increases, and if you test negative, it resets. So that's kind of the basics of it. In addition, with a CRA group, you have better retainment. They're all that book by Petrie has many different variations of it. I ran out and got it. He sells me these books. I'm not plugging but it's so practical. They lay out even the fundraising for it, but excellent evidence, high quality evidence, especially for stimulant use disorder, for which we don't have any comparative medications. I hope that gives a brief summary.
Yeah, no, thank you so much for that. And when I go into the behavioral approach, it's very much linked to that, right? Because you pick a specific behavior you want to reward, and it could be a negative urine, it could be attendance at a group, it could be sitting through the whole session, it could be a pat on the back when your spouse does the dishes, which is what I'm trying to convince my wife to do in some way. And then you want to have the timing close enough to the event that the person can associate that reward with that event, and it has to be of a significant magnitude as well, where it matches up and lines up, and that's where the challenge comes in, because in the open world, you're not in some controlled treatment setting. You're in a world where you're competing with fentanyl or other substances, and so if it's something where somebody wants to cut back on their use, it's harder to fully figure out and apply. So that was a phenomenal summary, and thank you for that. I'm not going to go into MI, because when I started giving talks, people would say, "Oh, I'm all MI'd out," and there's a lot of great resources and a lot of great experts on this. But it's a phenomenal tool for dialogue. It's a phenomenal tool when people are upset with you, to try to bring down the anger and aggression. And it's You sometimes feel a little bit less useful because you talk less, but the patients are more likely to follow through with the stuff they come up with for it, right? But that would be something for maybe for another time as well. And for those of you that look at the slides, this is a simple way to bring MI into your
Mhm.
medical practice when you need to give an evidence-based recommendation, right? And so how do you give that recommendation? And it's covered in this motivational and interviewing healthcare book. That's not for you to buy, Josh. Please don't buy another
No,
book.
no, no.
But the motivational interviewing healthcare talks about this EPE, where you can just elicit, hey, what do you know about the treatment for this? Would you be interested in hearing what's worked for others? And then you provide those recommendations. Then you ask them, you elicit from them what they've learned about it. And it takes about 15 minutes longer for me to do my assessments when I do this. But I know if the person's completely against medications or completely against therapy, or they're willing to try something, and then I can spend that extra time really making sure that area that they want to work on, I'm giving them those suggestions and stuff as well. I just had this slide here because I think we don't talk enough about engagement. And one of the things that I've learned a lot from Josh is that you can't just say take a medical textbook or a psychotherapy textbook and say, I'm going to go do this, right? You really have to think about the context. And we were chatting back and forth quite a bit before this around approach for specific communities, stuff around peer support. And so I'm not sure if you had a couple of ideas you wanted to share, because you work with a.
Well, yeah, because I'm working in rural indigenous, or working with mainly rural indigenous communities. And the first thing that I had to learn that was appointments were not going to work. And the health centers were no-go zones. The one health center, there were experiments done there, and so they're associated with horrible things. And so getting out of the office paired with outreach from the community, and again bringing the harm reduction supplies, and being flexible, doing MI on your feet, and just those simple things, those simple adaptations, saw a great influx. I have to credit the doctors with whom I'm working, because it was really with COVID that they're going to where people are at, literally really saw an influx of engagement. But doctors from the community as well told us, like, you got to go out and see the people. So this Jaganash learned a thing or two. Yeah, but I'm sure there are other examples that other people here can think of in terms of working with different communities and in different locations. What adaptations may be necessary. Um, I don't see anyone popping up, but and Wiplove, I'm sure you have many thoughts as well.
And when I think to some of the hardest days when I've worked in this field, they usually involve, when you visit public health agencies, you visit harm reduction facilities, you talk to people with lived experience, and you hear about the harms that have been caused by the medical field. And so here you are using your medical model, bring your A game, and then when you hear about these atrocities, it's very upsetting and unsettling. But it's also something where it makes us wonder, like, how can we reduce whatever those barriers are, right? How can we reduce that hierarchy so people do feel comfortable coming, they do feel comfortable coming back, and it's not just a perpetuation of previous trauma in these encounters. And I find all these conversations very, very tough. That's why I sometimes stay a little bit superficial. But the stuff you talk about is absolutely true, and when I think about when I moved from CAMH to St. Mike's, the population there, the medical acuity was so much higher and the motivation was so much lower to get help, because to see me back when I was at ChemHB, now they have a RAM clinic. But back in 2012, 2013, when I was there, you had to like book an appointment. They had like initial intake, and then maybe 4 weeks later on a random Thursday, you could see me at 1 o'clock, and it's just not going to work for some of these really, really complex clients. And the one thing I do love about the RAM model, and even the way that Tim Guimond set up the groups, it really was this fixed time every week. People can sort of drop in, and then once people are coming, the metaphor I think he always used when saying was that once a boulder is rolling, it's much easier to change the direction than to get it started, and stuff like that. So, all right, let me. So that was just a little bit about engagement, but when you see the names on the list, it's a bit uncomfortable talking about this stuff because there's a lot of great expertise there as well. Um, I'm going to cover thinking behaviorally quickly as well, and the book here related to that is the Getting Your Loved One Sober, although that's more the therapy for family members. Because for me, when I learned about CRA, it was the equivalent of when I learned what a thought record was for depression in terms of cognitive behavior therapy. And it's one of those things where all of a sudden you can't look at the world the old way anymore, but it's also upsetting when you think about how long you've been practicing and you've not been always using these approaches. And so community reinforcement approach was developed by Robert Myers in New Mexico, and it was developed around the same time motivational interviewing was by Bill Miller. And when you think about where and what was going on in New Mexico at that time in the early '80s and so forth, it was a time where AA was a predominant therapy. And so I think when Bill Miller talks, he talks about how you'd have to come to a center at like 6 a.m., you'd wait there in the heat for 2 hours. Then they would do full day assessments, like 8 hours, to see if you really, really wanted addiction care. And the people who got through it got a really, really high success rate. But what do you do for the people where that other model there sort of wasn't working? And Robert Myers did his postdoc or PhD, I should know which one, with this guy Azrin. And so Nathan Azrin is the one, he developed this toilet training for developmentally delayed adults with severe developmental delay. He developed the token economy system for people with schizophrenia, which has very, very good outcomes in shaping behavior. And so he's already in this world where he was sort of thinking behaviorally. And it really is just an expansion of this whole idea where you have an antecedent, you have some kind of behavior, you have a consequence, you have some kind of a trigger that happens, and maybe there's some kind of experience, there's some kind of behavior you do that it probably has some kind of a short-term reward, and it has a long-term consequence for it as well. And the one of the foundational parts of it, I'm just going to list the other ones off, is a functional analysis, and you can do it for an unhealthy behavior, you can do it for healthy behavior, and basically it's just walking through the events. So you'll have these external triggers where you try to figure out from the person who they're with, where they are when they use, and when they tend to use. You want the most common pattern, because it's going to be different whatever you come up with for Friday night versus Wednesday morning. Same thing might not work at those different times. You have them go through their internal triggers. So what are they thinking, and then what are they feeling physically and emotionally. You go through the problematic behavior, so what they do, how much, for how long, and then you spend a little bit of time getting the short-term positive consequences. You have to be careful when you structure your session, because if you end on the short-term positive consequences, they're going to be really excited to go out and use. And the first time I did this, no, but it's true, right? Because
Yeah,
in the MI literature, the last 5 minutes, that's what the person is most likely to do, right? Like it's if they're
now,
saying yes, yeah, sorry, yeah.
no, no, no. Finish that thought. I have a
You have a nice
follow-up
story
question.
after, yeah. So, like, is it so? What do they like about drinking with who, where, and when? And what are the pleasant thoughts, emotions, and the physical sensations they have? Because then you realize that, oh, is that the time when they don't feel alone anymore? Is that when the anxiety goes away? Is that when they're excited? 'Cause we forget sometimes people use when they're celebrating, and then you want to make sure you go through the long-term negatives as well. And once people go through it in detail, they start to realize that this short-term positive consequence, I need a healthy way to get that experience, which never happens right away. It takes a while. And then they realize that that negative long term consequence is the same thing that gets them to use in the first place, right? But it's this exponential process when you go through it. So,
Yeah.
Josh,
Well, I was just going to ask you regarding the functional analysis. Um, what about people's level of tolerance for such an exacting tool? Is there a type of patient that you would say this needs to be done with later on, or is there a way that you can shorten this to meet a person's window of tolerance?
yeah, I mean, I remember the first few lectures on addiction that I went to. We had people that would say, "Well, what do you like about it?" Right, just so you know what you're sort of up against. And when you get
Yeah,
the history of an evening, I mean, I'll eventually get them. But the first time I actually have it in front of me, I fill it out as they're talking, because then I can just
yeah.
do the random boxes. I share it with them afterwards, and it's usually later on that I'll teach them how to do it. Right, although to be honest, sometimes when I'm in that medical mindset and alcohol withdrawal, I don't do it explicitly, and I was doing it a lot more when we had the groups that were up and
Yeah,
running.
I think it's even good for people just to be in the habit of thinking, what is the function of this? What are the external and internal triggers
Yep.
when doing the assessment, even if they're not doing that the full sheet or whatever. Yeah.
Yeah,
Anyway.
absolutely. And it's one of the things where the other reason I emphasize it, because it's a gap, right? So you look at there was that program the province rolled out, this online program. I forget what it was called. But when you go through those modules, they spend so much time talking about what are the triggers, whatever, hungry, angry, lonely, tired, whatever that is. They talk about the long-term consequences of it, and then they also try to figure out what are behaviors to avoid it, right? They don't actually talk about what does the drug do for you and how to replace it with healthy things. And it's such a obvious thing when you see it. I mean, if the only way you can deal with your nightmares is by drinking, like, how are you going to come up with something else if when you stop all you get is the nightmares, right? If it's the only way you can be social, your anxiety is so bad. So I just it's and you know what, the reason that I did the story, I should let
Mhm.
you finish, but it's um that's why I spent all that time talking about engagement, because this is more like
Mhm.
you've already hooked
Mhm.
them in. They're
Yes,
coming back.
absolutely.
They
I
can
just
tolerate
wanted to make
discomfort.
yes, I just wanted to make that explicit because this again is another one of those practical steps which is so helpful. And someone saying it's so straightforward and so refreshing. I also promised Jennifer that I would help move you along if we were only halfway through the slides. And I see we have about 10 minutes left to the formal questioning, but I
Perfect.
think people are engaging well. Keep on going however you're feeling with the number of slides we
Yeah.
have
So
left.
what I'm going to do is I'm going to share the main points, and then the main one or two take home messages, and you can keep these slides. I mean, I felt bad, Josh. You started plugging the
No,
echo
no,
thing. There's a
she
lot of ways
no.
to learn.
Oh yeah, yeah.
Oh yeah, but it's so but there's a lot of ways to learn this stuff,
Mhm,
right? So
mhm.
CRA has a bunch of different components, includes things like the analysis of the substance use, functional functional analysis of healthy behavior. They do something called sobriety sampling, where you try to negotiate for a period of sobriety, so they know what it's like to be in their skin. It was based a lot around CBT, or the rational emotive behavior therapy from Albert Ellis, which is like CBT, just didn't have as good marketing as Aaron Beck. And then it also includes things like job retraining, social. We weren't able to roll out all of these things, but some of the principles are stuff that we did do. And the main take home point here is that you really want to think behaviorally, and you want to help them replace the function of it, and it doesn't work right away. So for example, if it's just like, anything that's good for you usually doesn't feel amazing the first time you do it. It's usually once you've done it for a while that you start to get that reward. So for example, if you eat like a chocolate bar, your dopamine cells fire. You eat celery, it'll fire, right? But it's after 6 months of eating that crappy celery that the dopamine fires and fires and fires. And so that's the CRA piece. The other piece that I wanted to share was around the family aversion. And so this is a slide just from the CCSA. So this is an evidence-based psychotherapy where if my brother is an alcoholic and he's drinking heavily and refuses to get help, you can do the therapy with me and he'll be more likely to enter treatment. I think there's about 4 or 5 RCTs on this. And that's where that book was, Getting Your Loved One Sober. I usually give out 10, 15 copies. And if a patient comes in and they have a family member who uses, or their partner's outside and they're okay, I give them that book. And for a few patients, because I've done the training, if a family member is extremely interested, I'll sometimes offer it, or I'll have a colleague offer it as well. But I won't go into the details on that. But this is the book that teaches you how to do it, and this is just the guide for patients for it, right? Because and this is, I mean, this is why the behavioral thing is so important. You think about contingency management. What are you doing? You're shaping the environment so the person is more likely to succeed, and that's sort of what they're doing here. But they also teach them a bit of MI. They teach them a bit of communication strategies. Like you can't always. When it's someone we love and someone we care about, the smallest comments can trigger an eruption, and it's a reminder of some of those basic principles. Okay, so that's the CRA piece. Robert Myers has a website. He has a couple days training. A lot of these newer therapies that are forming, either implicitly or explicitly, they'll use similar principles. So a lot of the family therapy versions use similar principles. For personality, I just dialectical behavior therapy. This is how I ended up learning it. I picked up these 3 books. This book here I feel like I'm selling books again, but this one on the left, is like, how you read a book, it tells you what it is. This book just tells you how does that individual therapy session work out. And these were the 2 books. And for me, I think I went through a 10-week 3-hour week training with Shelley McMain. Tim Guimond set up a psychologist to co-facilitate with us and have a supervision session for about 24 weeks. And then I joined a DPT consult team that he was running for a couple of years.
Whip, the Craft family one, is that Getting Your Loved One Sober? Is that
So
no
this is the
no?
one that's for patients, and
And
this is the
then
one that's for the therapist.
are
Uh,
those the ones you were asking for, Deanna? Yes.
yeah, that's one
Okay,
that Deanna was
wonderful.
asking for, right? So
Yes. We had an interesting conversation about the DBT addiction module, um,
yeah,
and some of the problems they may pose for people used to using a harm reduction. Uh,
yeah, yeah, and I think
uh, Go ahead.
a lot of these therapies come from the states, where historically addiction treatment is very much AA based, and so I think it's really important to help our clients use the words that don't fit as a chance for dialogue, right? I still remember, a few patients I ran into early in my training where, I mean, you're trained not to call people an alcoholic. They're like, I'm an alcoholic. I've been sober for 30 years. And who am I to say that like this person that was near death is now living a fulfilling life? And so I think like I try to really see it for dialogue, because the Seeking Safety book has a lot of language as well that we would not use at all. But the material is solid. And when you talk to Lisa Habits, or you watch how they implement it, they roll it out in a way that's so patient centered that all the differing viewpoints lead to dialogue and growth.
J-
Um,
Um, Jennifer's asking what the tension. It's a deliberate tension, and the tension is between abstinence and use. So the goal is abstinence in the
Yep.
DBT module. That's the second edition. I don't know if it's changed.
Yeah.
It's adaptable though.
Yeah.
I
Yeah.
think that's the point.
Yeah, it's
Yeah.
almost implicit, in some cases explicit, where the goal is abstinence, and you're either in abstinence or moving towards it. So it's really important that you share the modules in a way where your audience can hear it and get something out of it. But I mean, all of DBT is about that, right? It's all about that acceptance and change. Like I mean, DBT, a lot of it is CBT principles, but it's just packaged in such a way
Mhm.
that
Mhm.
even if somebody uh, has strong emotional reactions, they can take it in a little bit easier, right? So, but yeah, I mean, this is all stuff I've learned after. I mean, I theoretically I must have known it. I mean, I got through my exams, but the application piece I definitely learned when I was out in practice, and the trauma piece, I just found back when I was at St. Mike's, I think women's college back then, and Fred Victor had groups available for women. I didn't have a place to see the men that I was seeing, especially the ones that were using crystal. And sometimes, I mean, I don't know the data, but sometimes the perpetrators were the opposite gender and stuff. And so I didn't know what to offer them. I didn't have a place to send them. And so when I came across this, I spent the time, I did the training. A few of my colleagues did the training. We started offering it. And even though the pure PTSD people argue that it's not a treatment for PTSD, I believe it's when I think trauma informed care, I feel it embodies all of those principles. And when I think about people I've worked with trauma, where they have no anxiety, but it's because they've been avoiding the world, they're so focused on safety. It's a great gateway to other treatment, and people do believe the addiction components, the intensive case management components work. So I think with trauma, I really think about seeking safety as a potential stream. And Gene Tweed, an organization in Ontario where the patients I know that have been there have had phenomenal experiences. Like, women that I wasn't able to get them in a group environment, all of a sudden they're participating in groups, they're showing up regularly, they continue for a year after. And these are people that don't trust anyone, right? And so there's some magic that's going on there. And for me, like, I really think we I mean, I don't want to be using the medical model too much. I just think some patients we see have trauma. Some people have PTSD, and I believe that all of them deserve at some point in their life, if they're in a place, to get access to PTSD treatment, right, or at least a
Yeah.
trial of PTSD treatment. So
Yeah, and it's a good first stage for some people who may then want to go dig deeper and do the more intensive.
yeah, so it's about 8 o'clock, and I think there's a few other slides around how this stuff is linked. I don't know why I did this hodgepodge thing. I feel all of you here are so skilled, and I just wanted to throw a few ideas, and the ones that are important to you in your practice are going to stick. I really believe it. And the main framework here is that I was thinking in terms of a RAM clinic. How do you engage somebody in? What are the addiction medicine stuff? Let's not forget to think behaviorally, and then long term, what are some of the specific therapies that we can offer the people that we're seeing, especially around the psych piece for it. And then this figure, I just like it, right? Because I feel like I can think, what should we be doing therapy wise for the addiction itself? What should we be offering for the trauma? And Josh, this is where you're talking to me about the prolonged exposure. You shared the papers with me, and I think the Medify group. The data is there, right? You don't. No one has to
Mhm,
be 100% abstinence to benefit from PTSD treatment. And then
mhm.
the personality piece. And I don't know if it's reflection where I was working, I wasn't sure where else to send them, because I'm pretty sure people are more complicated than just a behavioral thing for addiction. Is there trauma? Is there like emotion dysregulation? But I just really sort of like that approach, and I really believe once you have the engagement, almost anything else is possible. And
Wh-
then once
Oh, yeah. Finish that thought, and
Yeah. So once you have the engagement, anything's possible. You can eventually come up with a framework for a 2 to 3 year plan where they could have their trauma treatment treated, or at least offered evidence-based approaches for trauma. You can offer behavioral approaches for the substances, so it's not just you can do it, just stop using, white knuckling it. If they have some impulsivity or personality traits, you can offer things for that as well, and it really allows you to dive into the details. So it's not just I used a bunch of crystal this weekend. It's really about diving down, because there's that moment where people don't have control, but maybe an hour before they knew that, hey, I'm not in a good place, maybe I shouldn't go see that friend. Or the day before, they're just like, I should probably cancel that trip to see that person, I'm not in a good place right now. And so it's the devil really is sort of in the details for it. So I'll leave it at that for now. I have a couple of cases potentially for discussion. I've seen some of the names on here, and I've met a few of you at various points, and a lot of you are extremely knowledgeable, and I suspect people I don't know are as well. So let's just see where the dialogue goes. Oh, and Josh, you had things to say as well, and then I kept talking.
Well, I was just curious. I had two follow-up questions, but I also see some really great comments, and I see Jennifer's popped up in the window too. So I can kind of wait on what I was going to ask and see what comes out from the others here. Some great comments.
Yeah. And if you sense a bit of frustration, you can embody that spirit and say it, say it, Josh, and I can be the one on the defensive.
Well, I see I see an opinion being shared that I've heard expressed. I don't know if it's a misunderstanding or if it's just an older thought regarding addiction, that someone should get a handle on their addiction before they can treat their co-occurring mental disorder. We did mention COPE, which is aimed at treating concurrently PTSD and substance use disorder. It's a prolonged exposure therapy. So there are certainly therapies aimed at that. Both Whip and Jennifer will be much better versed in treating concurrent disorders than I. What have you to say there?
Yeah, I think we have to think a lot about the training. We also have to think a lot about the service need. There's a lot of people with the schizophrenia, bipolar disorder, people that need depot injections, people that and I think like just the same way that in the 80s, some of those treatment programs required a very intensive screening process to see who got into the treatment programs. People like to see people that they're helping and that they see get better. And with the traditional psychiatry model, where you do a one-time consultation, maybe you see somebody 3 times a year, every 3 months, I've not had a great success treating people who use drugs. But when it's linked with intensive case management, when it's linked with maybe addiction medicine, definitely with peer support, it's like this magic thing where all of a sudden people come and they show up on a regular basis. And I think the data is clear. So eventually, we're not going to, I mean, what is it, 17 years that when some evidence comes out till it goes into practice? So, I mean, I think all of our psychiatry colleagues are doing their best, or working the way that they're trained. In some cases, people do better when you treat the addiction first. But what do you do for people that the addiction's still there and the mental health symptoms aren't there, right? And so, but I think that's a whole new sort of a topic around it. And thanks for bringing that up. I just feel we're into this in medicine. I can open up shop anywhere, and my wait lists are going to be forever to be seen. And so there's not that intense to see complexity.
So I would say I think the dogma is still very much alive, that you've got to treat the addiction before you can treat the mental health. And then of course, there are people in addiction who say, well, we can't treat your addiction, and vice versa. So I think a lot of us on the front lines are the ones who are trying to slog through and manage both, and for better and worse, probably relying on pharmacotherapy for both the substance use and the mental health pieces, until we hope people get to a place where they can do more of the other work that's there. Not that they're not working very hard all the time. I know that they are, but engaging in a different way. So I have a few questions. I guess one is, on a practical basis, Whip, you alluded at the beginning to the fact that many of us are sort of coming from a family practice model. We're wearing that hat. We know we've got to sort of prioritize. We're always trying to get a lot of things done. And in an addiction medicine clinic, we are often thinking about the medication. So we need to assess withdrawal and station and side effects and doses for the pharmacotherapy for the substance use, as well as the meds for the mental health and anxiety, as well as, what other things might be popping up in terms of, the medical and psychosocial. So engagement runs throughout, but where is the space? And is there sort of, other than just the reading of the person in front of you, like a structure in terms of a visit where that lends itself better to trying to focus on the interventions that you're talking about, knowing that we still have to get done all those other little pieces, right? How do you try to balance that? And I know that might not be the way you see patients all the time, but how would you guide us?
Yeah, I mean, I end up seeing patients in the model where my colleagues see them as well, right? And so when I talk about this pie in the sky, where you have psychosocial and everything there, it's not been in every environment that I've worked in. And in fact, I'm not sure it's the best use of resources to have physicians provide the full psychosocial
Mhm.
approach, right? When you think about resource allocation and so forth. As physicians, I feel like we're almost a little bit lucky because we build the government, right? So I don't have to get a hospital to hire me to do therapy. I can just sort of do it, right? Like I have that freedom and liberty. So I think it's a complicated question. I'm just going to come back to this figure here because the stuff that you talked about, Jen, I really see it as these two. I see it as the engagement and addiction medicine piece. And if you so happen to do like Hep C in your clinic, you do some primary care, maybe you'll sprinkle that on in addition to it. And when you think about how busy the day is, we don't really have much time to do more than this at all, right? And so it would require some creative planning, some creative sort of structure for it. And just like the way you've seen the different RAM clinics in different cities, they're all adapted to their local context. And I think there's creative ways to do that for psychotherapy as well. And my pie in the sky, I mean, my simplest thing would be, is there a way that we don't have to exclude people who are using drugs in the psychotherapy streams? Is there a way to add a component to the psychotherapy pathways where you can guide them to that sobriety, or you can guide them to a place where they're not using during the session or they only use after the session? So I think there's a lot of but room for creativity around the implementation piece, and there's strong signals that when you treat both concurrently for a couple of substances. I think there was one for trauma, there was one for depression and alcohol, but there's signals there that there's value. And the stuff around the opiate literature, it's really clear that when somebody is using heavy opiates, they have the withdrawal. You do want to get them on buprenorphine or methadone first, but for the mental health symptoms, the therapies are still helpful after they're stable for the comorbid conditions, right? So I'm just talking. I know I didn't give you an answer. I just feel it's so specific. It's like almost like me saying, make sure you give naloxone, or make sure you prescribe naltrexone, or like, yeah,
I
no, but
am
there's a lot of,
it
yeah,
to belabor this point, and maybe there just isn't an answer, because I know some of our colleagues, do CBT or other types of forms of psychotherapy, and are also prescribing OAT, for example. So is there a rationale for getting the prescribing done at the beginning and then spending your time on the psychotherapy, or spending your time on the psychotherapy and wrapping up with the sort of OAT adjustment, or does it really not matter? I don't mean necessarily that there's evidence for that. I mean, in your experience, trying to
yeah,
sort of.
yeah. Go ahead, Josh.
Oh, no, no, sorry. You can answer, Jennifer. I'll follow up. I'm
Honestly, I just when I'm in a RAM environment, I just want people to come back, and I feel
Mhm.
like once they're coming back, you can be that gateway. And I think It's all you're going to recommend what you believe works, and if you believe something works, you're going to be the patient's going to be more likely to believe that it works, and so for me, the biggest value in going through these therapies, learning it, and providing it, is that I've just seen the benefit, and so when I know, so it's not like so in 2012 when I was finishing my fellowship, I was like, okay, let's do a 3-week program. Okay, it didn't work. Let's do a 3-month program. Okay, it didn't work. Let's do. It was like this black box of addiction treatment where I was like for psychotherapy, I would never have said that. I would have said, okay, you need interpersonal therapy. Okay, you need CBT. You need exposure response prevention for OCD or whatever it is. And addiction was just like, oh, have you been to treatment? Oh, they've already been to treatment. But what's that treatment? And so I just think once we start getting into the nitty gritty, some ideas are going to pop up. And for family docs, I would love it if the addiction medicine piece was incorporated. For psychiatrists, I would love it if they included in their assessment and recommendations. I don't have to give everyone buprenorphine enough. People are giving people buprenorphine. Just include that in their recommendations, and eventually we can get to the point where we include the behavioral stuff as well. So when you have someone that sees you, you'll have done a couple of screening questions for borderline personality, for PTSD, and you'll make sure that in the note it's very clear they have these diagnoses, and these would be the evidence-based treatments for it. Because in medicine, I mean, this is a silly metaphor, but in medicine, like we don't say you have to treat the diabetes and then we can treat the heart. You can treat the heart, then the diabetes. And I'm pretty sure, like, if you have borderline personality, substances is not an exclusion criteria where DBT is not going to help. I mean, maybe it can make it harder to attend. Maybe you have to take more time in the commitment sessions. I hope I'm making sense. I'm not saying like every family doctor needs to do these psychotherapies, and it's not realistic, but family doctors and physicians have more power than we believe. And in the cases where we've been able to roll it out, being a physician, I have much more power than let's say a social worker, where they may have to do what the organization has hired them for. And in a couple of the cases, we found community agencies. We've gotten permission for them to get temporary privileges to do the stuff where there's a lot of people that want to serve, and there's a lot of creative ways to integrate and implement this stuff. And when I think back to the first Medify Arctic thing, what were they doing? It was anti-craving meds and buprenorphine. And now look at the breadth of what's being offered. So anyways, I'm okay. Josh, sorry,
No,
I'll
I
pause.
think this I think this touches on the point I was wanting to make, and on a comment in the thread. Um, I work in a team, and we're doing team assessments, a physician or an NP along with a counselor. And I think that's a helpful approach. And we see Elizabeth here in the comment thread saying that they're working along with peer support workers too. So again, there's a really, I think, self-conscious in a good way, dynamic, helping to address some of those power imbalances, and the imbalance of knowledge too. Not every physician is going to have the lived experience, and
And
I
if we did, we
go
probably
ahead.
wouldn't share it, right? Like it's
Right.
and so the peer support is it's magic for engagement. Like I think of so many people that wouldn't talk to me, no matter how cool I try to act. Like I dress casually, like it's just you don't have that cred, right? And there's something about, yeah, I don't know, it was magic, and it was also upsetting because then I realized I've been practicing for 3-4 years, thinking that I was doing it properly, and then there's this such a simple but thing that just transforms people's lives. So
There's also a really specific question from Jennifer, asking us to share our approach with intrusive symptoms during PTSD, and how your patients have done clinically. They were saying that they spent the last year learning more about trauma therapy, and some people insist that there's no need to wait for stability. I was commenting that that's a similar thinking behind COPE, but there is some commitment to abstinence during sessions there. Whip, do you have thoughts?
Yeah, I mean, for me, this is where the assessment also comes into play, right? So I didn't include the addiction assessment here, but at some point during the assessment, and it might be a longer session or it might be like 5, 10 minute sessions, I'm going to figure out if they have PTSD, and I'm going to figure out in terms of their typical day, how has it stayed with them? Is it nightmares? Is it flashbacks? Is it that they're not leaving the house? Is it that they're having these intrusive thoughts or intrusive images? And once you get those cluster of symptoms, you can sort of decide what's the pharmacological thing that I'm going to do to reduce their suffering, and what's the plan of treatment I'm going to engage them with. And I find it so personal to the individual. So, for example, what does seeking safety do? They're like, it's like the Bessel van der Kolk, the body keeps a score. So they're all about let's get outside of the body, let's connect with nature, let's connect with the world around, let's use those sort of those grounding skills to get out of it. But if you look at a lot of indigenous forms of healing, they actually almost lean into that thing, right? And so when you look at what Teresa's Marsh has done with her adaptation of seeking safety for indigenous populations, she's integrated both of those philosophies in terms of outside of the body to ground, but also sort of leaning in. And when I'm working with people that have trauma, I want their day to day life to be um, functioning, and then when they're ready for the therapy, you want them to be successful. And even though in the cognitive processing therapy, I think it's between 20 to 40% in the studies in terms of the dropout rate, and so I suspect it's about 1 in 2 in terms of people I've worked with. I really think this complex PTSD, whether you believe in it or not, or whether you believe it's borderline plus PTSD, there's something to be said around DBT followed by prolonged exposure or cognitive processing therapy. There might be something with this DBT plus PTSD treatment that's also out there as well. But those are my thoughts. I just want them to function on a day-to-day basis. Make sure I'm not missing something. I think in Alfredi's comments, she talked about if I treat the symptoms, it helps a lot. And I find for some people, once you get them on a good dose of OAT, they're not having the withdrawal, they're not having those symptoms. But there's other people where you get them on a good dose of OAT, especially buprenorphine, boom, it's all of a sudden the flashbacks and all that stuff come back, right? And so
Mm.
I really try to think about who is this person in front of me, and I try to do my best to personalize both the pharmacotherapy and the psychotherapy and the timing and so forth, right? Because I just feel everyone is so unique, right? Every depression is different, every generalized anxiety is different. So I hope that answered a little bit.
I'm guessing that others listening to the call are, hearing you talk about DBT, EMDR, CPT, I'm thinking about EFT, all of these things that require funds, or
Yeah.
do they? Right? I mean, yes, there are some psychiatrists, and I guess physicians who could choose to train and provide some of those services. What do we do? How do we access? Do you have any sort of tips? Are there still any? I know that there was a pilot, and I think a CBT or an IPT pilot that was running that was going to offer virtual OHIP funded care to people. Do you think that any
Yes,
of the online, whatever the big white wall, and now I'm blanking out on the other one.
the breaking free.
Breaking free we use a
Mhm.
lot. I refer to
Yeah,
a lot. Yeah.
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 I go ahead.
When you get to complexity, none of this stuff is really helpful. The way that it's designed, the way that it's rolled out, and yeah. I, I'm not sure what to say or how to say it. I think there's a lot of creative opportunities or solutions. I think people that see the most complex patients aren't at these tables where they're coming up with designing models and how to get things done. Some of the clinicians I've learned the most from, their clinical schedules are so full that I don't see them at these higher level meetings doing the kind of care and the planning for this stuff. So I think it'd be a great discussion on creative workarounds. What Mel and the women's college team did with the RAM clinics, I think at first when it was rolling out, part of me was like, oh, they're not doing enough. But he almost found the perfect way to get that foot in the door. And then all of a sudden, all these other opportunities opened. And when a couple of years back, before it started to spread, I talked to colleagues in Alberta and Vancouver, they were blown away, like, how did you guys do this? And I was like, it was just so, I think there's creative ways around the psychotherapy piece. I think right now, there's some great check boxes. I think some of these approaches aren't going to serve the people that we work with, and they're going to require a bit more creativity and evaluation and Yeah, but it'd be fun to chat about. I'm not. I mean, most of my ideas come from the time that I've had with Tim Guimond and his team, and then
Mhm.
all these other experiences I've had that leapfrog from that experience, and it came from a window of 3 to 4 years where we had a lot of freedom and control over what we rolled out. So, for example, if I didn't have a caseworker, I made friends with 3, 4 caseworkers from community agencies. I talked to them about, hey, why don't we train you? See one, do one, teach one. We'll bring you in for 6 months weekly. And then we had these groups running where you had someone who was super skilled, someone just learning. I mean, there's all these creative approaches. I mean, I just, yeah, I'm not even sure what to say, right? I mean, like, yeah, there's a lot of creative approaches for this, and it'd be great to brainstorm
Mhm.
and then do something and then evaluate it, find the effective component, and spread that. But the sandbox is it's a very competitive space, right? And how to, yeah. So I, I want everyone to leave with a hope,
I
right?
appreciate that,
So
'cause my
Mhm.
negative energy is, okay, we've identified trauma and the need for trauma therapy, and now someone's gonna sit on a waiting list for a year and a half for group and not individual. So I appreciate
Mhm.
the challenge to be creative and be collaborative and try to build things, but it doesn't totally replace mine
I No,
well,
frustration.
our the one local service has gone to group only,
Yeah.
to deal with wait lists.
yeah.
So, yeah.
Mhm.
Yeah, like I just when I think about these last 10, 12 years after I finished my fellowship, I just think about how uninformed I was 10 years ago around how do you approach pain, how do you approach the medical comorbidities, how do you talk to somebody where um, they may not want your help. What do you do for family members where they're like, my son's not coming in. What do I do? And then when you start to do PubMed searches, there's all these evidence-based treatments, but they're not readily accessible or available. And so for me, it's always been, who's this person in front of me? How can I help figure out what to do there? And then once you get good at it, your wait list is too long, and then it's like, how can I spread it? And the first part is attitudinal, and Medify's done phenomenal with attitudes. I mean, everyone here, nobody here says, "Oh, we should never use buprenorphine," right? Or, "Hey, like we don't need peer support." Nobody thinks that. And so I just think there's a lot of approaches. And for me, I think I try to spend maybe half a day a week trying something sort of semi-new, and if I'm in an environment that it's supportive, and then it sometimes spreads and sometimes it doesn't.
Mhm.
Um, the 4 or 5 things that I've learned are paired with like 6, 7 things that didn't take off because it wasn't the right timing, or we didn't have the patience, or I didn't have the right team around me. And I think we're capable of so much more than we can imagine. I did not imagine buprenorphine being an issue. Like I thought I would be spending a long time convincing psychiatrists you have to prescribe buprenorphine. I don't even need to worry about that anymore, right? Like methadone, buprenorphine, it's like everywhere. And so like when I see about how fast that happened here in Ontario, I'm like, this other stuff is definitely possible too. And that's why I give these talks. I don't like hide. I'm not like, oh, I'm not going to tell anybody about craft. I want to have a super craft program because people do phenomenal stuff for the people that they're seeing. So, okay. Oh, and thanks for the comment around Gene Tweed. I'm a big fan around Gene Tweed. I saw your comment earlier around Julie, around what do you do for specific cultures, what do you do for specific genders, and I've always avoided those conversations because my only experience is with the people that are in front of me, and it depends where I'm working, who they are. So I don't have that breadth of knowledge. But Gene Tweed, I've been blown away by the experience patients have had there, and this is for the last 10 years, right? I'm shocked that at the difference between how they are once they finish versus where they were when they started. And so, anyways, okay, I'm gonna mute because I could go on. I'll let you both.
That's a great segue,
No,
though.
I
Do
yeah.
you want to spend a couple minutes maybe talking about what I'm presuming is integration between psychotherapy approaches and cultural approaches in the team work that you're doing
Um, I can I
there?
can speak to uh, I can speak to our end of things.
Yeah.
We're working closely with members of the community, both at Saugeen and Neshaming. Um, so these there are clinicians through the health center there, and then peer support workers who are to be hired at a future date. So this has been a collaboration that was established between the two communities and the local health services. So it's still kind of in the early stages, but the cultural programming is happening in the wellness center, and that's combined with the services housed in the same place. So on our daily outings, we're actually delivering OAT to people's doorsteps, and we're paired with an outreach worker from the community, seeing individual patients, and then returning to the wellness center where the programming is usually happening. There's also programming happening in and around the community. So it's as simple as that for the moment. We don't have any evaluation to provide yet, but I know that CAMH is going to be doing some of the evaluation at some point. I'm not exactly certain of the dates on that, but it is exciting, and it has been just growing and growing and growing. And I think the big thing for me has been learning and understanding the communities that I'm in, and the outreach team is just amazing. And these are people who were hired from the community, and are now getting trained by our doctors from the different health services, and also doing other training. So capacity is being built too within the communities. So it's just a really fantastic partnership, and I'm certain there are similar things being done like this elsewhere. I know there are. We've heard about them through Medify, but for me, this has been the last 2.5 years for me. And I think that kind of answers what you were asking. Yeah. Okay, good. It didn't really speak to the specifics of the therapy and the cultural aspects. Go ahead.
No, but it's the whole thing with there's nothing for us, without us, right? And you're co-developing, you're going where people are, you're there's so many elements that you didn't say it explicitly, but it's implied in the process where this was developed and how it's evolving. So yeah, I think you did cover that. But yeah, so.
Yeah, and I think it speaks to the flexibility and the dynamic nature of, figuring out where you are at a moment in time, and what the community needs, and how to leverage and resources, and then build together, right? And what comes from that. So I want to thank you both so much. Especially for the challenge to not just say, oh, none of these things are funded. What are we going to do? Why are you telling us about all these great therapies that our clients can't access? To thinking about how we can read more, think more, incorporate some of these strategies ourselves, and get creative about how to try to build partnerships and access services. And as we said, not to forget those really core elements of engagement. I think that can't be overstated, right? The power of the relationship and meeting somewhere where they are, and then that the growth that happens there. So thank you both so much. Please complete your evaluations. Our May webinar, always the second Wednesday of the month, is on managed alcohol program with Graydon Simmons from Ottawa. So I invite you all to join us for that. Josh and Whip, any last words? Thank you, everyone, also for the resources that you shared in the chat. I really, really appreciate that. And I think many of us and sort of jotting those down to save them. Yeah.
Thank you, everyone.
Yeah, no, thank you everyone for taking time to listen, and I think there's ways that we can have that hope and spread it to our patients, and hopefully this talk has given you a couple ideas that can potentially grow into hope as
Mhm.
opposed to this how are we ever going to tackle this this problem. So
Yeah,
thank you.
and I think that, yeah.
I do feel that. Thank you. And energized rather than discouraged. So that's wonderful. It's a great way to end the night. Everyone seems to be really pleased. Thank you so much, everyone. Happy short week, happy holidays, whatever anyone is celebrating, and we'll hope to see you in May. Bye, everyone.